All right, so I'm going to take over for the next talk because I'm standing between you and the lunch, so I'll try to be brief. I'll try to catch up. So I'm going to actually play the tag team with Dr. Crook, who mentioned about the endocarditis treatment from surgical perspective. And one of the complications that rare complications can be seen with infective endocarditis is cerebral mycotic aneurysms. Mycotic aneurysm obviously is infection of the vessel wall causing weakness, aneurysmal dilation, which can happen anywhere in the body, right? So when you have the infected source from the cardiac valves, then that can deliver the bacterial emboli or whatever fungal or the pathogens to any parts of the body. Theoretically can cause aneurysm. But I'm going to focus on the neuro aspect for the cerebral mycotic aneurysm. I have no disclosures. These are the learning objectives, just to give you an overview of the etiology, pathophysiology, and history of cerebral mycotic aneurysm, and with some clinical emphasis on clinical and imaging characteristics associated with infective endocarditis, including their dynamic and elusive nature. They are not so easy to detect and also to manage. Often, within constraints of other factors and comorbidities. And as Dr. Cook and many of our colleagues, speakers mentioned, a multidisciplinary approach with hypervigilance to the diagnosis and management of cerebral mycotic aneurysm, especially those antibiotic refractory cases, are very important. And now some case studies as examples. So a brief history of mycotic aneurysm. William Osler was one of the big four professors that founded Johns Hopkins Medicine, many regarded as modern medicine. In his 1885 Gustonian lecture in London, first coined the term mycotic aneurysm as a description for meningeal complications of endocarditis. So we have known this entity for over 1 century. Before that, there's only about 3 dozen or so cases reported in the literature. So cerebral mycotic aneurysm is a distinctive type of aneurysm than the rest of the aneurysm we know of, including a fusiform aneurysm, which is the circumferential dilation of an aneurysm wall along the axis of the vessel. And pseudoaneurysms are the different vessel wall, different layer dissection, actually a protrusion because of weakness, injuries. A sacral aneurysm is the most common type of aneurysm that we encounter clinically that has the vessel wall protruding because of various risk factors. And dissection is injury of the vessel wall, and rupture aneurysm, of course, can happen to any of these type of aneurysms. The nature of the infective disease process involving mycotic aneurysm make it much more vulnerable than many of these other typical type of aneurysms because their inflammatory process underlying and also infective nature. As you can see over here, there's a bilobulated infective mycotic aneurysm in the middle cerebral arteries on this patient, which is one of the examples I'll show you. So what are the characteristics of the cerebral mycotic aneurysms? So they tend to be irregular in contour, could be multilobulated as you saw, and often can be segmental and multifocal because these are infectious in nature. They can actually be deposited in different parts of the cerebral vasculature, and they can actually generate air or thrombus in the wall of the vessels, which can be detected on imaging. Infective endocarditis related cerebral aneurysm tend to be have medium or small vessel involvement because of the relatively slow flow compared to the large proximal vessels. They tend to latch on to the distal vessels through the vasovasorum. And most actually are and can be responsive to antibiotics, although chronic cerebral mycotic aneurysms usually are associated with calcifications. So they can present actually as both ischemic, hemorrhagic, or focal or diffuse neurologic deficits. Sometimes can cause seizures or cerebral edema associated with the inflammation infection, can cause diffuse findings clinically. And rupture can lead to obviously devastating hemorrhages, including subarachnoid hemorrhage, intracerebral, and intravascular hemorrhage, and meningitis as the other alternate, actually the other important complications for these patients with high mortality. So the cause of endocarditis obviously can cause mycotic aneurysm, including sepsis. They can be bacterial, as Dr. Crook mentioned, but also can be fungal, and also viral as well, especially for those with immune compromised status, either or immunosuppressed status, including TB, aspergillosis, and viral VZV and herpes. I've seen another case of HIV infected young lady with a giant MCA or ICA aneurysm due to, we think, some VZV infection chronically, and which is not operable. And of course, IV drug use and focal infection, including trauma, sinusitis, otitis media, can also cause infection, injury, and affecting the cerebral vasculature. Lastly, iatrogenic certainly can cause that as well. What do we know? William Oster coined the term of cerebral mycotic aneurysm. So as Dr. Cook mentioned, a significant portion of that actually can be associated with infective endocarditis for these patients. 14 to 40%, and about 5% of infective endocarditis patients can experience hemorrhages, mostly related to the mycotic aneurysms. Nearly 9% of infective endocarditis may have mycotic aneurysm on pre-operative angiographics screening. So it's not trivial. It's nearly 10% of patients. Within that, about 2/3 of patients may have confirmed when you have a mycotic aneurysm, they may actually have endocarditis. So vice versa, you find something that's intracranially, you may want to look deeper using TE to see whether they're having endocarditis. And obviously, the mycotic aneurysm related hemorrhages mortality could be as high as 80%, more than the typical regular aneurysms that 40-50% mortality range. So they are high morbidity mortality and easy to rupture. 50% of them could easily rupture. So I came across this case report in the literature with a fungal cerebral mycotic aneurysm. It's a 17-year-old patient with Addison disease with obvious immune compromised status. Came in with the 2 weeks after she had a left trigeminal nerve ablation, a V1, V2 segment, presented with a fever and onset, pupil-sparing ptosis. And this is the arrows point to the aneurysm actually in the left cavernous ICA aneurysm on the left side. It's bilobulated, as you mentioned, which was actually embolized with the flow diversion pipeline stent. However, she had unfortunately suffered catastrophic aneurysm rupture and died the next day, despite the treatment. Obviously, she was doing a therapy for the stent placement. And histopathology study reviewed the aneurysm, the ICA aneurysm, and also the cavernous sinus, including H&E staining, and also the special staining for fungal debris actually confirmed fungal infection. So this could be a potentially iatrogenic introduced infection and with secondary aneurysm formation. So I'm going to have another case. I got a couple of cases where we treated cerebral mycotic aneurysm over here in collaboration with our CT surgeon colleagues over here. So this is a 46-year-old right-handed male smoker with poor dentation, which I think has some quite interesting and significant association down, well, I'll show you why I say that. But no other past history basically presented new onset headache and dysarthria and right-sided facial droop with bilateral lower extremity weakness to an outside hospital. Found to have the typical presentation for infective endocarditis with fever, acute CHF, multi-vessel mitral valve, multi-leaflet mitral valve endocarditis. Had a 3 out of 6 diastolic murmur and was found to have dental abscess actually starting on antibiotics before transfer to Maimonides for cardiac surgical evaluation. CT head and CTA outside reported was negative for acute stroke and bleed, and the blood cultures confirmed strep mytitis and aurelis. These are oral floras that are in the causing the infective endocarditis. So the CTA actually from outside hospital we reviewed so there's areas of irregularity over there. They didn't mention anything, but one of our neuroradiologists picked it up, and we actually admitted her into the CTICU, and this is the angiogram. We're showing there's actually mycotic aneurysm, small one over there. It's right there. And he was tested COVID negative, continued antibiotics, and so the CT angiogram, had a cardiac cath as well. So he had triple vessel disease, so he was planned for combined valve surgery and also a CABG. But we found this 7mm left MCA, middle cerebral artery M4 fusible mycotic aneurysm. So we're facing that dilemma that Dr. Cook mentioned during his initial part of the talk when the case, the young patient that he's encountered as a fellow. So how do you handle this patient with a infective carditis that clinical symptomatic, needs to have surgery, but have a intracranial infective mycotic aneurysm? So what are the options over here? Right, so we can potentially continue antibiotics to observe, but when do you cross the threshold? Clinically, he's symptomatic, right? So if the antibiotic doesn't work, you have to go for surgery. But with the amount of anticoagulation, as Dr. Krug mentioned interruptively, is that safe, right? And if not, how do we treat it? Endovascular embolization, how and when? And if not, should we do surgery as the other case was done previously? What about something else? Do we put this patient on aspirin? So these are all the questions where we face at the time. So we wanted to see whether the antibiotic can make some difference or not, because a relatively small 7mm aneurysm, if it's stable, and so we actually followed him with a serial imaging intracranially with CAT scan. This initial presentation, can see that's probably the mycotic aneurysm with the surrounding edema. Over there, there's no hemorrhage at that point. A week later, 6 days later, you can see looks like there's increased enhancement or increased actually hyperdensity over there. We don't think it's necessarily bleed. We think it could be the aneurysm that's enlarging with worsening edema. So we did a CT angiogram the same day. Indeed, the aneurysm looks like it's larger than before. Now what do we do? So we decided to bite the bullet to go ahead to treat this using a technique I learned from Dr. Patel. We actually decided to embolize this aneurysm. You can see the aneurysm is quite different than the initial presentation. That was kind of subtle, but now it's obvious it's enlarging, now become more than 11 millimeters within a week. So it's like a balloon is about to pop. So we have to treat it emergently. So these are the techniques we use. A balloon-assisted septic balloon is actually have a balloon at the tip of the microcatheter. You can actually thread all the way into the vessel and proximal to the aneurysm, and using inflation of balloon and using the onyx technique that Dr. Patel showed for treating AVMs to embolize, to seal off these enlarging aneurysms. We actually, I particularly like DMSO onyx for these treatment because DMSO potentially can be bactericidal, so it can almost like sterilize the distal segments for these vessels. We use the balloon test occlusion to analyze the eloquency of the area, just like Dr. Patel mentioned for AVM resection surgery. Eloquency of the brain matter actually does matter for the outcome. If you take out the vessels, it cause big stroke, then even though you treat the aneurysms, but the patient had permanent deficits. So we did that, and he was able to tolerate the BTO with the somatosensory evoked potential or motor eventual potential with the balloon occlusion for 15 minutes. So you can see that we threaded microcatheter. I threaded microcatheter proximal to the mycotic aneurysm and inflated the balloon and did the balloon test occlusion. Then we used, with the balloon inflated, we inject the onyx liquid embolic material to seal off this aneurysm. We purposely actually inject the onyx beyond just aneurysm segment because oftentimes the distal segment or surrounding area are also affected by this infection material. And this is the onyx cast. After the embolization, he developed moderate dysarthria right facial droop, and the right arm was actually near-plegic at the time, despite our BTO. So there's probably vasospasm and also the edema associated with the embolization. And his essentially was intact. It's in the motor cortex that's there. But the next day, his symptoms actually quickly improved and essentially recovered later on because of collaterals flow from these vessels. Because one thing that's important to remember, these aneurysms tend to be localized in the distal vessels that often can have collaterals from other vascular territories, retrograde. So they may recover some of the function. So he was transferred, he had some hypotensive episodes and back to the CTICU, and eventually he was discharged home with 4 weeks antibiotics with a PICC line, with a plan to, so this is a post-embolization CT. You can see the onyx material, you can see there's no bleeding, you can still see some there's artifacts from the embolic material. The edema, everything stays the same. So radiographically, it's a pretty good treatment outcome. So he was discharged home, and we did actually repeat CT head and CT angiogram before his planned surgery on the 13th, a week before, and there was no bleeding, no new stroke or new aneurysm detected at the time. So, however, post-op day 1 after the cabbage and mitral valve repair with tissue valve and also concurrent left atrial appendage clipping. So he developed dysarthria, severe dysarthria and bilateral ataxia, NNH 1 to 7 from 3 at baseline. And the CAT scan showed this, a left cerebral hemorrhage, which is really unexpected, right? The lesion we saw was in the left MCA territory, which we embolized. That didn't bleed, but she had a left cerebral hemorrhage. We treated him, put on the Queenie watch and give her hypertonic saline. He fortunately did not require craniotomy. He was able to improve gradually with the medical management. The MRI showed no new stroke anything. So he was readmitted later on, discharged and readmitted later on because of non-symptoms. So the question from this is whether the angiographically we didn't detect a possible affected segment of the left cerebellum in the vessel. So potentially that could be where they bled interruptively. There's some significant edema associated with that. Eventually, he recovered well with only right-sided, pulmonary drift. So he went back to work. So it's overall a good outcome from the patient. So I want to have quickly go through the second case before I summarize what we can say about it as mycotic aneurysm. So the second case is also recently treated over here, was transferred from outside hospital with a fall, with right-sided weakness discharged through a facial droop. And CT showed subarachnoid hemorrhage and also left frontal intraparenchymal hemorrhage. Initially, there was question whether this is traumatic or not, which we didn't think so. She also presented with a fever and briefly and bacteremia, which is Staph aureus and Actinobacter. The study antibodies over there, of course, CTA reported was again unremarkable. Came here for treatment for the management of the bleed and also a seizure. We did the high resolution CT with reconstruction and saw a suspicious possible small aneurysm over there, which can be mycotic over there on the CTA. And the MRI brain and initial presentation showed significant hemorrhage, there's diffusion and flare and gradient echo sequence with significant vasogenic edema. This is something that's almost like a telltale sign, is that the edema from the hemorrhage is kind of out of proportion from the inflammatory process, not necessarily just from the vasogenic or compression. And 2 weeks later, they showed additional edema. But the bleeding relatively stayed the same. So I did a 3D angiogram initially, and including the 3D reconstruction, which I couldn't really see the mycotic aneurysm really well. But retrospectively, there may be a tiny aneurysm over there. So they can be very elusive. So we have a delayed repeat DSA angiogram on about 2 weeks later, which showed actually confirmed mycotic aneurysm over there. So again, we use the embolic liquid embolic onyx material, same approach, balloon assisted embolization for that. And you can see the liquid embolics, the onyx cast over there, and the aneurysm's gone. And she underwent, well, of course, you can post-op, you can see expected increased ischemia from the embolization area sacrificing vessel, but otherwise the bleeding is stable, the post-op onyx cast over there. So she underwent the aortic valve replacement with a tissue valve without events. Interestingly, she was also found to have antiphospholipid syndrome subsequently, and has to be started on anticoagulation initially on Eliquis, but switched to warfarin. So just saw her in the office a couple of weeks ago, that she basically back to her baseline presentation when my facial droop discharged to right prone drift. So overall, she's avoided a disastrous event potentially. So I mentioned the first case that actually had dental abscess causing associated with the mycotic aneurysm. Actually, there's considerable literature linking the intracranial aneurysm development with, including mycotic aneurysms, to dental infection, either chronic or acute infections. So in this study from Korea, South Korea, in the Korean National Health Insurance System health screening cohort, they studied 200,000 patients registered in that registry and found to have about 1%, about 2,100 patients developed unruptured aneurysm over 10 years, meaning follow-up. And during that, within that cohort of 2,100 patients with aneurysm development, they found significantly increased risk, actual association for those with periodontal disease with unruptured aneurysm. So this is significant. So this is association, but may not be causation, right? So actually, we have the crime scene suspect DNA detected. So in this study, the authors detected bacterial DNA species within the aneurysms resected intracranially, and the bacterial DNA streptomyces, as in our first case, is actually most common dental flora over there. And also they have their highly immune response associated with this. So bacterial DNA was detected in 70% of the in this study with ruptured aneurysm. And both ruptured and non-ruptured aneurysm can have the bacterial signatures in there. So this is a proposed mechanism for the inflammation and infection caused the chronic infection, weakening the vessel wall, inducing aneurysm formation. So the take-home point, I think, from the experience we have is that there could be a dental health linked to the intracranial aneurysm formation, including mycotic aneurysm. So make sure you go see your dentist and hygienist regularly. And infective endocarditis, internal endocarditis related mycotic aneurysm could be dynamic. It could be elusive despite aggressive antibiotic treatment. The hypervigilant vascular surveillance with MRA, usually I would recommend with contrast study, CTA or angiogram is warranted before, I would think, valve replacement surgery to prevent catastrophic intraoperative fatal ruptures. And then the vascular treatment is feasible, reasonably safe, and should be considered for aggressive and progressive cases. And multidisciplinary approach, team approach, again, is very important. I'll stop here and take any questions, and any question you may have for Dr. Crook as well. Yes, Dr. Agarwal, please use the microphone.
Thank you, Tony. I have one question for Dr. Crook. Dr. Crook, I know you mentioned the surgical aspects. Is there any surgical criteria for the valvular lesion to be a particular size when you consider the candidate or surgical versus medical management?
The size criteria pretty much comes from prevention of embolization. You know, we look at people whether they've either met indications for valve surgery, for destruction, valvular dysfunction, but there is that subset of patients who have floppy 10 millimeter, 20 millimeter vegetations, and they're at risk of embolization. So a lot of people talk about 10 millimeters in this country, especially on the mitral valve and otherwise asymptomatic patient, as somebody may need urgent surgery to prevent catastrophic embolization.
If a patient has embolic appearing strokes and if the vegetation is small, would you still consider that patient a surgical candidate?
Vegetation is small and the horse is already out of the barn. They would just treat that with antibiotics unless they had a different indication, you know, valvular destruction or invasive.
Thank you so much. And one question
Yes.
for you, Tony. If, you know, patients are not going for valvular surgery, you know, if you're just continuing medical management with antibiotics, but they also have an indication for anticoagulation, such as atrial fibrillation, in those cases, would would you rule out a mycotic aneurysm before you can safely put them on anticoagulation?
I think that's a similar question that I asked about bleeding and anticoagulation in this case. I would be very methodic and detailed to try to assess that risk. Because these are long-term anticoagulation requirements. And if a myocardial aneurysm is present but not treated or not visualized, they certainly can pose risk because they have higher risk of rupturing than your typical psychoaneurysm, as we discussed before. They can also carry consequences. So potentially, I would start with a CT angiogram with high resolution and do a 3D recon to look at this with experienced neuroradiologist. That will be my first line screening. And if everything looks good, then it's reasonable to start. If you have any suspicion, any irregularity of vessels and the size, I would go for a straight angiogram to give a definitive assessment. If you need it, you need to treat embolized and, assuming it's embolizable segment, then before long-term anticoagulation, because these aneurysms tend to spontaneously rupture because of infective progressive nature. If you have anticoagulation on top of that without securing aneurysm, they are higher risk.
Thank you so much.
Thank you. So there's a question in the audience saying, why did I put someone with bleeding on Coumadin? That's counterintuitive, right? So in this case, remember, we didn't put on the Coumadin right away after the initial hemorrhage. We waited. We started on the aspirin until it was stable because he had actually ischemic events as well, secondary to the myocardial aneurysm. I mean, secondary to the infective endocarditis. And once we found her to have antiphospholipid syndrome, she actually had a DVT and PE in the past, which we think is probably from the antiphospholipid syndrome as well. So that required long-term anticoagulation. So once we secured aneurysm, the bleeding source is secured, we started anticoagulation, and there was no issue. The hematoma gradually resolved. I don't know if we can go back to the last slide. You can see the CT follow-up. That's other than the honest cast, there's no hemorrhage. So that's fine for anticoagulation for this situation, despite the hemorrhage. That's why we have the multidisciplinary approach. The timing is very important. One to operate and one to anticoagulate. It's an individualized process. Dr. Wang, please use the microphone.
A very brief question for Dr. Cook is that during your valvular surgery for these patients, would you anticoagulate the patient during the surgery? If you do, then would you reverse them?
Well, you have to do anything on the valves. It requires open heart surgery, stopping the heart and opening it up. You have to use a heart-lung machine. So we're now talking about 300 to 400 units of heparin per kilogram just to get started. Much bigger doses than they're used to using on the medical wards and in the surgical wards in the hospital. So they're catastrophically anticoagulated in order for us to do our job. If you don't reach these anticoagulation targets, then people have catastrophic DIC and fatal consequences on the heart-lung machine.
Great, thank you.
Thank you. There's another question. Do you recommend every endocarditis patient being assessed for surgical surgery obtaining a DSA for myocardial aneurysm? I think that my question is the same as the previous question that Dr. Agrawal mentioned. I'll start with a CT angiogram or MR angiography with contrast to screen, and then based on the findings, and then go from there. MRI too, because there are often other clues besides the vessels. You have inflammation, you have edema, you have other clues actually to help you to determine the risk of myocardial aneurysm presence. Then you go for the definitive assessment. But keep in mind, DSA also has its detection limit. As we mentioned, the cerebral hemorrhage maybe is beyond what we could see. It's less than 1 millimeter or sub-millimeter. That can be disease at the time, but not detecting, or this thing could be dynamic. When we did the DSA, they didn't show anything. Later on, they did. So that's just keeping that in mind. Yes.
Yes, along the same lines, it is not a class 1 indication, but it says it may be reasonable to screen left-sided endocarditis. But my question is, I agree with screening left-sided endocarditis for cerebral prior to surgery. Would you want a stroke team consult as part of the preoperative workup, or would you just give us a test you would prefer that we order and call the stroke team if we have an abnormal finding?
Right. If you don't have neurological findings, you do a pre-screening. I think you can order it yourself. Then have the neuroradiologist take a closer look and maybe do make sure they do 3D reconstruction. You can see the vessels better, give a higher resolution. I think that will be something we do. I think people are free to go grab lunch. It's outside to see. But folks who are interested can stay. And then we'll put up the sign for there's a question about the CME. Yes, I think that will be something I would do. If it's not having symptoms, then you can just order. If you're having neurological concerns, call us. So I think that will be a good way to screen these patients. I think there was another question for Dr. Wang. Maybe Dr. Krug can answer the left atrial appendage closure complications. What are they? There was a question online before.
We're talking about standalone or concomitant at the time of open heart surgery?
Maybe both.
Concomitant, it's kind of a freebie as long as there's no adhesions back there, and you just have to be careful of the corners. I have seen one circumflex compromised, but I think it's relatively straightforward. They tend to retain a little fluid post-operatively. The standalones, which I think is a great procedure for people who can't tolerate
Open heart surgery.
Can't tolerate anticoagulation for chronic AFib. It's done through a left chest VATS approach, which I think is a great procedure.
Yeah.
Because once it's done, and I think the biggest things there are bleeding, which is rare, but can be a problem. And you're very close to the left phrenic nerve, so you have to be careful of that. But those are the only real complications.
Great. We do that routinely over here with Dr. Uderman.
Yeah, I think it's underutilized, and I hope we can write a paper on it.
Yeah, we will.
We can popularize this in the greater New York area. I think it's very important.
Yeah, very much so. Thank you.
More question.
Yeah, Dr. Levin was our neurointensivist director.
Up on the previous question, a bit more specific. If you have a patient with an intracerebral hemorrhage in the setting of endocarditis that you suspect is an embolic event with hemorrhagic conversion, would you want a formal angio before the patient's going to have surgery in 4 to 6 weeks to rule out mycotic aneurysm?
Yeah, that was a question asked before. Yeah, I think that I would go for the CT angiogram or MRI with contrast first and do maybe MRI just to make sure there's no other signs or go from there. You can argue, should every single patient go for angiogram, the quote unquote gold standard? I think if we think it's high risk, potentially we could. But if it MRI, CTA, CT head, MR angiography, all negative, the pre-test probability is much lower than if you have something suspicious.
Got it. Yeah, when we see a hemorrhage, we're obviously a lot more worried.
But you're not certain. I think angiogram is reasonably safe to perform. Just to be more confident. Again, nothing is 100%. As we mentioned, it could be under the threshold of detection as well. There could be evolving as well.
Thank you.
Welcome. Thank you. Let's break for lunch. We'll be back at 1 o'clock. We'll have a quick lunch over here. But thank you so much.